welcome you all after the short tea break. We have here with Dr. Vishnu Adhane. He is a consultant from Jalna. Now he'll be speaking on fetal heart, right? Sure. Thank you. Welcome, Vishnu.
At the onset, I am thankful to Team Marathwada RadCon for giving me this opportunity to present on the fetal heart. To start with, remember that most of the CSDs, about 80% are seen in a low-risk pregnancy. Only 20% are seen in a high-risk pregnancy. So the basic fetal cardiac screening and fetal echocardiography should be integral part of all anomaly scans. As the fetal heart is a too small, complex, dynamic anatomic organ, one has to follow the universal protocol or guideline for the evaluation of the fetal heart. Now these are the planes of scanning of the fetal heart. These are the axial planes or the transverse sections of the fetal upper abdomen and thorax. The first plane starts from the transverse section of the fetal abdomen. That is abdominal situs, 4-chamber, then outflow tract, then 3-vessel view and 3-vessel tracheal view. The abdominal situs, 4-chamber, 3-vessel view and 3-vessel tracheal view, these are the true transverse planes or true axial planes, while the outflow tract, that is LVOT and RVOT, these are the slight oblique planes. Now the International Society of Ultrasound in Obstetrics and Gynecology recommended 6 basic views for the fetal cardiac screening, and they also recommend the use of color flow for the evaluation of the heart. These basic views are, this is the abdominal situs, this is a 4-chamber, this is a LVOT, this is RVOT, this is 3-vessel and then 3-vessel tracheal view. Now how to obtain these views? This is a sweep technique. This is a sweep from the fetal stomach to the fetal neck. Fix the probe over the transverse section of, take the transverse section of the fetal abdomen and fix the probe over the transverse section. Then angulate towards the fetal head, you will get a 4-chamber view. Then again angulation towards the fetal head, you will, and slight tilt towards the fetal shoulder, you will get LVOT. Then again angulation and slight tilt to the fetal left shoulder, you will get RVOT. Then 3-vessel view and 3-vessel tracheal view. Collectively, this is a sweep stomach 4-chamber. Now from the 4-chamber, angulate towards the fetal head and tilt towards the fetal right shoulder, you will get LVOT. Then towards the fetal left shoulder, you will get RVOT. Then 3-vessel view and then the 3-vessel tracheal view. To start with, most important is to know the situs of the fetus, that is the right or left side of the fetus. There are many methods to know the side, right and left side of the fetus. You may keep a doll over the maternal abdomen according to the fetal position and you may identify the situs. But keeping a doll in ultrasound may be controversial. Second, you may assume yourself in the womb according to the fetal position and you may identify the right and left side of the fetus. But the most convenient method is relationship of spine, stomach and umbilical vein. If the fetus is in cephalic presentation, the spine, stomach, umbilical vein, these are in a clockwise rotation. Here you can see this is cephalic presentation, spine, stomach, umbilical vein, these are in a clockwise direction. So this is left side, cardiac apex on the left. If the fetus is in breech presentation, the spine, stomach, umbilical vein, these are in a anti-clockwise rotation. So this is the left side, cardiac apex on the left side. Here again breech, here you can see spine, stomach, umbilical vein, these are in a anti-clockwise direction. The normal arrangement of internal organ, that is a stomach on the left side, cardiac apex on the left side, is a normal situs solitus. Mirror image of situs solitus is situs inversus, that is stomach on the right side, cardiac apex on the right side. Anything in between these two, that is situs solitus and situs inversus, is situs ambiguous or a situs heterotaxy. Coming to the views, first view is a abdominal situs. You know how to identify the right and left side of the fetus. This is left side, stomach is on the left side, liver parenchyma is on the right side, but most important is the relationship of aorta and IVC. Aorta is slightly left to the spine, IVC is anterior and to the right of the aorta. Four chamber heart. Fourth chamber may be apical four chamber, lateral four chamber, basal four chamber. In apical four chamber view, you are scanning the heart through the apex and also know your color setting. Towards probe is a red. Both the inflows are moving towards the probe, so they will appear in a red, while the outflows, they are taking blood away from the heart, away from the probe in the same direction, so both will appear in a blue color. Lateral four chamber view is the best view for the evaluation of interventricular septum and the ventricular wall thickness. And in basal, you can see the atria are well visualized and pulmonary veins well visualized in basal four chamber view. Now coming to the apical four chamber view. This is checklist of apical four chamber view. Every point in the checklist is important. Situs size, cardiac position, cardiac axis, two atria, intraatrial septum, two ventricles, interventricular septum, two AV walls, midline crust of the heart, two pulmonary veins, area behind the heart, and contractility and the rhythm. Situs and size. You know how to identify the situs. This is left side. Stomach is on the cardiac apex is on the left side. Roughly speaking, this is thoracic cavity. 1/3 is occupied by the right lung, 1/3 is occupied by the heart, and 1/3 is occupied by the left lung. You may calculate cardiothoracic circumference ratio or cardiothoracic area ratio, and that is 0.25 to 0.35. Cardiac axis, if a line is drawn from the spine to the sternum, second along the ventricular septum, then this angle is a cardiac axis. Normally the cardiac axis is a 45 degree plus minus 20 degree, so it becomes 25 to 65 degree. There may be a right axis deviation or a left axis deviation. Coming to the cardiac position, if the line is drawn from the spine to the sternum, it divides the thoracic cavity into two equal parts. This is left, this is right. 2/3 of the heart is on the left side, 1/3 is on the right side. This is a normal position. This is a levocardia. If the heart is in centrally placed, then it's a mesocardia. And if the heart is in the right hemithorax, it's a dextrocardia. Here you can see heart is shifted into the right hemithorax, and there is a herniation of the stomach into the left hemithorax. Dextrocardia may be a dextro position or a dextro version. Here you can see heart is in the right hemithorax, but the cardiac apex is still facing towards the left side. So heart is pushed into the right hemithorax. So there are external extracardiac abnormalities that is pushing the heart into the right hemithorax. Here you can see this is C-palm of left lung pushing the heart into the right hemithorax. Left pleural effusion, left diaphragmatic hernia, they causes the dextro position. Here you can see the heart is in the right hemithorax, but the cardiac apex is facing towards the right side. And this is seen in situs inversus and the heterotexy. Now coming to the both atria. Both atria should be equal in size. This is left atrium, posterior most chamber of the heart. Pulmonary veins opens into the left atrium. Foramina oval flap opens into the left atrium. This is the right atrium, this is anterior and to the right of the left atrium. IVC, SVC opens into the right atrium, best seen in a bicaval sagittal view. Intraatrial septum, there are two components, septum primum, septum secundum. In the mid portion of septum secundum, there is a foramina oval and its flap opens into the left atrium. Both the ventricles, you must see both ventricles are equal in size. This is left ventricle, this is the leftmost chamber of the heart. This is a elongated or a longer, the cavity is longer compared to the right ventricle. Smooth wall of the left ventricle, cardiac apex is formed by the left ventricle. This is right ventricle. Moderator band is seen at the apex of the right ventricle. Right ventricular cavity is short compared to the left ventricle, and it's a crescent shape, and internal surface is irregular or trabeculated. Interventricular septum, apical 2/3 portion is a thick and it's a muscular portion. Basal 1/3 is a membranous portion and it's a thin one. When a septal defect is suspected in the apical 4-chamber view, that should be confirmed in lateral 4-chamber view. Because IVS is best seen in lateral 4-chamber view, you can measure the thickness of IVC, that is 2 to 4 millimeter normally. Atrioventricular wall, you must see the opening and closing of both the atrioventricular wall and also the flow across both the atrioventricular walls. Tricuspid wall is more apically placed compared to the mitral wall. This is a midline crust of the heart which is formed by the membranous portion of interventricular septal leaflet of both the atrioventricular wall and the septum primum of the interatrial septum. Pulmonary veins, you must see a pair of pulmonary vein opening into the left atrium. Area behind the heart, this is a spine, anterior and to the left of the spine is a pulsatile structure, this is a descending aorta. Anterior to descending aorta is the echogenic structure, this is a esophagus. You may see a dilated esophagus during fetal swallowing, but as soon as fetal swallowing over, it collapses. And to the right and anterior to the aorta, this is a small circular vessel, this is a azygous vein. Normally you can see the azygous vein, but the size of the azygous vein is 1/3 to the size of the aorta. If the size become equal to the size of the aorta, then it's abnormal, it's a double vessel sign which is seen in a heterotexy. Contractility, left and right ventricular contractility should be equal. There is no paradoxical movement of interventricular septum. Heart rate 110 to 180 beats per minute. And it should be regular with no extra beat or other irregularities. Here, see the ventricular beats are followed by the atrial beats. Now coming to the third view. First, we have seen abdominal situs. Second, apical 4-chamber. Third one is a LVOT. This is the first outflow tract that is arising from the smooth wall left ventricle. You must see the septo-aortic continuity because most of the malaligned VSDs are located here and they are commonly associated with the complex outflow tract abnormalities. And second, you must see the aortomitral continuity. Coming to the fourth view, right ventricular outflow tract, second outflow tract that is arising from the right ventricle immediately divides into the right and left branch. Right branch is going posterior to the aorta. Left branch continues as a ductus and joins the descending aorta. Now coming to three vessel view. As name indicates, three vessel from left to right, this is the pulmonary artery, aorta, superior vena cava, PAS. Pulmonary artery is the largest one, middle one is aorta, superior vena cava is the smallest one. As the pulmonary artery is on a long axis, aorta will appear in a transverse section. Both the vessels are perpendicular to each other. And as you know, both the outflow tracts are taking blood away from the heart in the same direction, away from the probe, so both will appear in a blue, while the SVC is taking blood towards the heart and that will appear in a red color. This slide is just to show you the importance of three vessel view. By seeing only three vessel view, you can diagnose many complex cardiac outflow tract abnormalities. You know the normal pulmonary artery, aorta, SVC. Instead of seeing three vessels, if you are seeing only two vessels, then it may be a common arterial trunk or transposition of great arteries. If the pulmonary artery is a small in size but showing a normal antegrade flow, then it's a and you have overriding of aorta and malaligned VSD, then it becomes a tetralogy of Fallot. If the pulmonary artery is hugely dilated with hugely dilated its branches, then it's absent pulmonary wall syndrome. If the pulmonary artery is a small in size and that is showing a retrograde flow, then it becomes PA, pulmonary atresia. If you have VSD, then it becomes pulmonary atresia with VSD. Here aorta is a small, showing a normal antegrade flow. So it's a interrupted aortic arch or coarctation of the aorta. Here aorta is a small, showing a retrograde flow, then it's aortic atresia or critical aortic stenosis. Coming to the last sixth view, three vessel tracheal view. As name indicates, this is ductal arch, aortic arch, superior vena cava, and this is a trachea. Both the ductal arch and aortic arch are going to the left of the trachea and they forms a V. And on color, both are taking blood away from the heart, so both will appear in a blue color. This is a normal three vessel view. Look at this. This is superior vena cava. This is a ductal arch. This is aortic arch. Aortic arch, instead of going to the left of the trachea, is going to the right of the trachea. So it's a right-sided aortic arch. Here you can see this is superior vena cava. In front of the trachea, the aortic arch divides into the right branch and left branch. And one is going to the right of the trachea, one on the left of the trachea. So it's a double aortic arch. Collectively, this is the axial section. That is the transverse section. Sweep technique, stomach on the left side, cardiac apex. You must see the equal size ventricles, intact interventricular septum, normally opening atrioventricular walls, midline crust of the heart, both the atria, intraatrial septum, pulmonary veins draining into the left atrium, area behind the heart, and then the look at the first outflow tract arising from the left ventricle, septo-aortic and aortomitral continuity. Then the second outflow tract that is arising from the right ventricles divides into the right and left branch. Right branch going to the posterior to the aorta, left branch continues as a ductus, joint the descending aorta, then three vessel view, pulmonary artery, aorta, superior vena cava, then the three vessel, and this is a trachea at the level of carina. Now the evaluation of the heart at the 11 to 14 weeks. Due to improved ultrasound technology, we can evaluate the heart at 11 to 14 weeks, and the technique is same. Identify the situs of the fetus and the sweep technique. This is sweep from the upper abdomen. You can see both symmetrical inflows flow across both the interventricular wall. This is a left LVOT. This is a RVOT, three vessel view, three vessel tracheal view. This is a 14 weeks scan. You must document at least these three views in the ENT scan. First, we are taking tricuspid wall along the ENT scan. Second one is the inflow. You must see the both symmetrical inflows with a flow across atrioventricular wall, and both are in a red color. Second, outflows, this is a pulmonary artery, this is a aorta, both are taking blood away, both will appear blue. You should document at least these three views at the ENT scan. These are the few cases you can diagnose at the ENT scan. Here you can see this is left ventricle which appear globular, hypokinetic with minimal flow in the left ventricle. Look at the outflow tract. This is aorta which is showing a retrograde flow. It's a aortic atresia leading to HLHS. Here you can see there is a left axis deviation overriding of the aorta, and look at the outflow tract. This is a pulmonary artery. Pulmonary artery is smaller than the aorta. It's a case of TOF at the 13 weeks. Now look at the last one. This is a significant TR. IVS is intact. Right ventricle is small. And look at the outflow tract. This is a pulmonary artery which is showing a retrograde flow. It's a pulmonary atresia. IVS is intact, so it becomes PAIVS. So to conclude, fetal heart is a small, complex, dynamic anatomic organ. One has to follow the universal protocol guideline for the evaluation of the heart. CSDs are most commonly seen in a low risk pregnancy. So basic fetal cardiac screening, fetal echocardiography should be integral part of all anomaly scan. If you get an abnormality in a fetal cardiac screening, then extend the evaluation with the fetal echocardiography. And fetal echocardiography is like a mathematics. Follow the steps, follow the guideline, you will get the answer. Thank you so much for the patient sharing. Special thanks to Bimal sir. Thank you so much.
Thank you, sir, for such a wonderful presentation. Now I request our moderators to please felicitate Dr. Vishnu Adhane, sir.